Greetings, my name is Kathleen Steele and I will be moderating today's session. I would like to start today's webinar off with a quote by Perry Como. People have always thought that I wasn't ambitious. They judged by appearances and were fooled. I was competitive, I wanted success, and I was willing to work for it. Last week, we discussed cracking the fatigue code. And I wanted to take the time for a second and thank you for being part of our wellness community. And we realized that despite your busy schedule, you've decided to participate in this webinar to help yourself, your family, and your community live happier, healthier lives. And if you'd like to look more at some of our past webinars to kind of, if we talk about any topics and you've noticed, they are found on our YouTube channel, and you can also find them on the website and click the YouTube logo as you see on here. And feel free for future upcoming webinars to subscribe to our YouTube channel, and also on our Instagram, you can follow us at Restorative Lifestyle to find out upcoming webinars and more information. We ask that you please remain on mute during this and that you type all your questions that come up in the question and answer section rather than the chat section. The question and answer section is underneath of the PowerPoint and where we are talking. So without further ado, reversing Alzheimer's and memory loss using the ReCODE protocol. So I'd like to introduce Dr. Nadia Ali. She is the founder of functional integrative medicine practice, Functional Holistic Healing. She's been practicing for 18 years, board certified in internal medicine specialty, board certified in integrative holistic medicine, board certified in the American Board of Integrative Medicine, a fellow of the American College of Physicians, a member of the Institute of Functional Medicine, and she has certifications in the areas of nutrition, mind-body, Ayurveda, and Chinese medicine. You can learn more about her practice at www.theholistichealing.org.
Thank you so much, Kathleen, for that introduction. And now what I would like to do is I would like to introduce you to Connie Ivy. She is my star patient, and I have to tell you, I'm honored that she has chosen me to be part of her healing journey. So let me tell you a little bit more about her. She is an outstanding artist. And when I say artist, it's just not about being able to draw or, do photography. I mean, she makes jewelry. I mean, she's amazing. Every time I see her, she has something new that she has created. I think the other part of her personality is that she is a fighter and she is a survivor. And you will see that when she tells you her story, which is really fascinating and inspiring at the same time. She was a caretaker for about 5 years. So she has an immense degree of compassion and empathy towards those who actually go through situations of memory loss, because she herself has been through it, her family members have been through it. She actually overcame significant brain fog and memory loss. She felt it was really important for her because it was affecting her creativity. It was affecting her personality. And more importantly, it was affecting her ability to interact with her members of family. And she is a grandma, so of course you can understand how important that is. She overcame fibromyalgia, depression, anxiety, sleep issues, and chronic fatigue. The reason why she is my star patient is because she is somebody who follows things to the T, very hard work and very consistent. And when we say that people after a particular age give up on things, she is not somebody who would give up. And she studied botanical illustration at the Royal Botanical Gardens during age 37 and 42, prior to which she had no idea about drawing. And at age 50, she actually was awarded Hunt World Competition. She actually won that competition for the best at botanical illustration. So, I mean, that is really amazing. And that's what makes Connie Connie. That's the defining characteristic of Connie. So with that, what I would like her to do is to tell us her story, because I think we can all learn a lot from that story. And before I do that, here is her work. Amazing. So thank you for sharing that with us, Connie.
You're welcome.
And now all over to you.
Thank you. Hi, my name is Connie, and I'll tell you my story. At age 12, I had mononucleosis, which caused me to start having pain for the rest of my life. I went on, nobody knew why I was in pain, nobody treated it. In my 30s, I married, we moved 5 times, and I had a daughter. Between 43 and 50, my brain fog was so horrific because I had 3 antibiotic doses for a month each for Lyme disease, and nobody counter-treated that. I was a caregiver for my mother while my parents moved in with us in a 3-bedroom house, and I had a young teenager who was we had just returned from Canada, where she loved living and loved all of her friends, and now she's in junior high, and it didn't work very well. So anyway, it was a lot of work and very upsetting. And the dementia that my mother had came on at that time, where she knew that my daughter, she was cognizant enough to understand that my daughter knew more than she did. And it really angered her. So she was walking around either in a fog or in anger, especially if my daughter was around. And that was such a tragedy because she was mad for my child, so happy. I went to Amon's clinic thinking I had dementia and had brain scans and whatever. I chose not to stay with Amon's because they didn't do what I felt I needed, which was one-on-one healing. I wanted to know the steps. I wanted to know what I was doing. They did find out, that I had a mass of right in the middle of my brain that showed that I have depression. I mean, it's what I live with. But most people wouldn't say to you that I was a depressed type of person because I don't like it. So I choose to be happy. I choose to do things that make me happy. And that keeps me from being depressed. I found Dr. Ali, luckily for me, and we started a journey. The first day I was there, it was her normal, she interviews you and then you talk about things, and I took tests, or I, wrote things down and whatever. And she had a list of things that about as long as my arm that said, I think these are what's wrong with you. And so then I did testing. I had blood tests and I did and it was confirmed. And some of these things could have been healed if someone had treated me like she did when I was 12. And then when I was in my mid 40s to 50, all those things could have been dealt with because the brain fog was caused by the antibiotics and all kinds of things. All were treatable, and they have been treated. I will say that when we decided to do this, I looked at her as my coach, and I followed whatever she said to do with no questions. Well, maybe a few, but but if she always answered them so that I understood why I was doing it, and then I just did them because I didn't know what was wrong with me. I did because she told me, but I didn't know if we could get through it. But I figured if I didn't go 100%, then like she was, then I wasn't going to be healed. And I wanted the best life I could have. I'm now 71 and I am in no pain, haven't had any pain, and I don't have any brain fog. And so I will say, when you get over being as ill as I was, and you walk around and people would never think that I had anything wrong with me in my whole life. So I can say, really, work at this like you would want your best loved person to do. And if you could save anyone, you might as well save yourself, because you may need that strength for your own life to have fun and make up for what you missed. So that's my story.
Thank you. Thank you so much, Connie. And I'm so happy that, you at this age of 71 are so productive. And I hope that we can all do that till the last day of our lives, because I think everybody has to die. No question about it. But the question is, what is the quality of our lives till the end?
Right.
So I think that's important. So thank you for sharing your story.
Welcome. You're welcome.
So thank you again, Connie. And Dr. Ali, is Alzheimer's considered an epidemic, would you say?
Definitely. Right now, we are facing Alzheimer's disease as an epidemic, because if you look at the data, it's the 6th leading cause of death, with 1 in 3 seniors dying from it. Unfortunately, the number of deaths from Alzheimer's disease has increased by 146% from 2000 to 2018. Unfortunately, 2/3 of the sufferers are women. African Americans are twice more likely, and Hispanics are 1.5 times more likely to be at risk of the disease. The problem is not just the fact that these individuals suffer. We are talking about a lot of money and a lot of resources, because caregiver stress is huge. And that stress continues for years and years and years, and you don't know how long that stress is going to last. So this is a very devastating disease with progressive loss of brain function. So clearly, this is a disease which needs to be dealt with head on. Otherwise, we are looking at a lot of people suffering and losing productivity for 10, 20, or even 30 years, as we see that longevity is becoming a norm.
So how does dementia present itself? What does it look like?
So basically, if we look at dementia, the way we can diagnose it, the most important part of diagnosis is clinical manifestation. Now, it's very interesting that if you look at this, the staging of dementia, there are 7 stages. And the stage 1 is when we say there are no symptoms. What does that mean? That means that it takes between 10 and 20 years for the process in the brain to progress slowly to a point that it can get manifested. So stage 1 is that stage where there's a lot going on, except that you are not detecting it because the system is still not overwhelmed. Stage 2 is very mild decline, in which people will say, well, I forgot my keys, or I don't remember his or her name. And 50% of population over 65 will actually exhibit these signs. Stage 3 is mild cognitive decline. This is when people forget their appointments, they have difficulty finding words, there is reduced productivity. They will often tell you that they don't drive at nighttime or evening, they're not very comfortable with it. Stage 4 is when most of the time there is the possibility of diagnosing, because the loved ones can see that there's social withdrawal, because the person realizes that they have limited capacity, and so they withdraw. And so that's something which is detected by people around them, and they will often forget recent events. Unfortunately, there's a lot of denial of symptoms, because for us as we grow, cognitive ability is part of us, so it's very hard to believe that we are losing it. So you will often find denial at this stage. Stage 5 is what we call moderate decline, in which now you are actually seeing some major issues, like they're forgetting personal details, like they might be confused, they might be somewhere and they're thinking, where am I going right now? and they'll definitely have problem-solving difficulty. Stage 6 is moderately severe decline. This is when you actually are not even able to do the things that we do automatically, like there's incontinence, you're not recognizing your loved ones, you're having personality changes. And then the last stage is when you're actually forgetting things, like you don't remember how to walk, you don't remember how to talk. So those are the 7 stages of dementia. Now, the unfortunate part is that 50 to 80% cases of dementia are undiagnosed. And when they're diagnosed, it's quite late. And the problem is that the earlier you diagnose it, the more chances of complete reversal. So it is critically important that we make sure that we are looking at those little things that we talked about, like, okay, if you're forgetting things, if you're forgetting names, you really have to think, is this normal? Did I ever do that? Is this recent? And you really have to be looking at the whole picture to be able to make diagnosis early enough.
Are there any tests to diagnose Alzheimer's?
So the problem is that, we do not have the best tests or the most accurate tests. So one of the tests that's done to diagnose is that this is an invasive test where they take some fluid from your spinal cord. It's called the cerebrospinal fluid, and they look for proteins, beta amyloid, and tau levels. Now, the problem is that, if you have Alzheimer's, you may have high levels, but it is not necessary that you have high levels. You can have Alzheimer's despite not having elevated beta amyloid and tau levels. And that is why it's first invasive and second not accurate. There is one test though, and this is just recently, AAIC 2020 was the conference where this data was presented. It's a blood test for p-tau 217. And the researchers found that the levels of this protein were increased 7-fold in patients with Alzheimer's. But the best part about it was that the levels started to increase 20 years before the onset of cognitive impairment. And this is very important with people who have a risk for Alzheimer's. Like if they have the gene which is linked to Alzheimer's, then we know that they are going to have an earlier onset. But using this level, we can actually see if they are starting to do that, if they're going in the wrong direction. Unfortunately, this test is not widely available yet. But if that does happen, then it would be something that would be very helpful. We have other blood and urine markers, but they are neither accurate nor very readily available. So that is the problem with using these markers. As far as diagnostic imaging is concerned, there are 2 imaging modalities that are often used. One is MRI. MRI is used to look at structurally at the brain. And if you see shrinking areas, certain areas shrinking, then you can say, look, from this picture, we can say that there is possibility of Alzheimer's. And then there's the PET scan, which is basically a scan to look at the function of the cell. So it's more of a functional scan. And if you see reduced cell activity in certain areas, then you can say, well, it looks like this is an indication of Alzheimer's. However, these are not necessarily diagnostic. The place where they are more helpful is if you see a lot of contraction, a lot of reduction of brain volume, you know that you're dealing with a much more severe situation. Or if you see certain areas affected, you can say whether is this Alzheimer's dementia or is it another type of dementia. That is where they are most useful. Also, they do not necessarily predict if you are going to have dementia or not have dementia. So imaging can be used for supportive purposes, but it's not necessarily the end all be all as far as the diagnosis is concerned.
Are there any specific genes that we can identify to find who's at risk for developing dementia?
So yes, and before we talk about genes, the one thing which I think is very easy is to see if you have a first-degree relative with dementia. And then you know that your risk of developing Alzheimer's dementia is increased 3-fold to 4-fold. So that is very easy. So even if you don't have a test, you have that data, you can possibly tell what's going to happen. The gene that is most prevalent and has the strongest impact on Alzheimer's disease is the apolipoprotein E4. In short, we call it ApoE4 gene. This is a gene which is basically also called the fat bucket gene. It's on chromosome 19. It's called the fat bucket gene because it's like a bucket which carries fat. So it's a protein which carries fat, in the bloodstream. Now, 40 to 65% of people with Alzheimer's actually have this gene. The other thing is that we know that this gene is present in about 25% of the US population. We also know that if you have this gene, then your probability of developing the disease could be 10 to 15 years earlier than someone who does not have the disease, which simply means that just because you don't have the gene does not mean that you will not have dementia. But if you do have it, then it's a different story. If you remember, every gene has 2 copies. One copy comes from mother and one comes from father. If you have one copy of the gene, ApoE4, which is present in about 75 million Americans, your risk of having Alzheimer's is increased by 30%. If you have 2 copies of the gene, which is present in 7 million Americans, your risk is increased by 50 to 90%. Also, this gene has been implicated and associated with heart disease and insulin resistance. Now, the one thing that I want you to make sure you understand is that predisposition is not predetermination, which means that just because you have the gene, whether it be 1 copy or 2 copies, does not mean that you will get dementia. We are talking about increased risk. It does not mean that you will get it. So you have to understand the concept of epigenetics, which means that this is a type of gene. You can understand this with the example of a loaded gun. So you have a gun which is loaded, which means the gun has the bullets. If you have the gene, then you have the probability. But whether you press the trigger or not is in your hands. So if you are diagnosed, either you have a family history or you're diagnosed to have ApoE4, instead of dwelling on the fact that you have a loaded gun, what you have to focus on is how do you make sure that the trigger is not pressed? And that is what I would focus on.
So do we have any drugs to treat Alzheimer's?
So basically, if you look at the treatment for Alzheimer's disease, we have had a lot of failed trials of drugs that we thought would be amazing for the disease. We have a few drugs, actually. Unfortunately, none of the drugs that we have can stop the progression of disease. The drugs that we have, there are 3 to 4 drugs. They help symptoms in about 50% of patients who take them. But they usually stop working after 6 months to a year. And these drugs are most beneficial in the early stages of the disease. And they're not very helpful later part of the disease. And so we really have very limited options, which is the reason why this is a very devastating diagnosis if you only have the conventional way of treating it, because you really don't have many tools.
So we found these drugs that can work. Why have we not been able to find a cure?
So this is what I want you to understand. When we initially looked at dementia, and when more and more people were having dementia, one of the questions was, why are these people having dementia? So what they did was they did an autopsy, and they looked at the brains of these individuals to see, what's going on. When they looked at the brains, they found 2 things. The first thing they found was the amyloid plaques. You see the arrow here pointing towards it. These are proteins which are outside the cell. They found that the more amyloid plaques a person had, the more severe was the dementia. They also found some protein called tau protein inside the cells. So what they thought was that, let's suppose if amyloid is the problem, then why do we not get rid of amyloid? If we do that, then all the problem is going to be solved. So at that point in time, most drugs that came out were in one way or the other trying to get rid of amyloid. Unfortunately, that did not work because amyloid is not necessarily the problem. Amyloid is made in response to certain insults to the nerve cells. So if you take away the amyloid, but you don't take away the insult which is causing the problem, the insult will continue and the problem will continue. So, for example, if you expose brain cells to toxins like mercury, to infections like Lyme, like mold toxins, or if there is leaky gut going on, or there is inadequate nutritional support, then the cells will continue to not function. It is simply producing amyloid as a cry for help. It's a product as a result of the insult. So instead of trying to remove the amyloid, we should try and remove the insult, which is the reason why a lot of trials failed. And despite removal of amyloid, they did not see the kind of change they wanted to see.
So is there hope for those at risk suffering from dementia?
Definitely. So we will be discussing the Precode protocol, which is basically a protocol devised by Dr. Dale Bredeson. And this is a protocol which is to prevent the dementia from occurring. If you remember, we said it's a 20-year process. And so the earlier you're going to start, the better it's going to be. And the ReCODE protocol is how do you reverse somebody who has memory loss, somebody who has Alzheimer's dementia. And at this point in time, I want you to introduce you to Dr. Dale Bredeson. He is a principal investigator for the Alzheimer's Disease Research Center at UCLA. He was the one who devised the ReCODE and Precode protocol, and there have been thousands of patients that have actually done this protocol. He actually has an outstanding book. It's called The End of Alzheimer's, the First Program to Prevent and Reverse Cognitive Decline. I think he has another book coming out. If you're interested, you can definitely go ahead and read the book, where he has actually shown with a lot of research as to how the brain cells go from a point of normalcy to a point of malfunction. And we will be discussing the way he looks at the whole process, and you look at the protocol as well to kind of give you an idea about how we do this. The second physician who I really respect, I think she has contributed a lot towards the research with regards to the effect and impact of nutrients and lifestyle on brain function, is Dr. Terry Wahls. She has a book by the name of Wahls Protocol. It's a story which is very inspiring. She was diagnosed with multiple sclerosis and basically did everything, was in a wheelchair. This is her picture from October 1st, 2007. They tried everything. And then at the end of it, they said, well, we have tried everything. We have no other, interventions to give you to help you. At that point, she took it upon herself to kind of see what can she do. And this is her October 1st, 2008, riding a bicycle. And, she is a researcher. She is actually a wonderful person. She's a clinical professor of medicine at the University of Iowa, Harvard College of Medicine. And she's actually working on a number of research projects where she is trying to kind of help other people who are going through the issues and the health problems that she went through. So amazing and outstanding story. And the third functional neurologist that I want you to introduce you to is Dr. David Perlmutter. And I think that his contribution is really amazing. He is not only a neurologist, he is also a fellow of the American College of Nutrition. He's written multiple books, and he is an expert in the field of Parkinson's disease. And he talks about the impact of the gut on brain, the impact of the gut bacteria on brain. And if you're interested, definitely I would recommend you to kind of look at some of these people. They have a lot of YouTube. You can find them on YouTube. They talk about the work they have done. And we are all very indebted in the functional community to these researchers and these neurologists and functional physicians, because they have done a lot of research to kind of help us validate. Knowing is one thing and validating is something else. And they have really helped us validate what we knew for a long time.
So what is the first step in initiating the ReCODE and Precode protocol?
So the first step, and this is a term coined by Dr. Dale Bredeson, he calls it cognoscopy. I think he's gotten it from colonoscopy. So if you know that when we are age 40 or 50, we are asked to do a screening colonoscopy, which is basically an assessment to screen a person. And so cognoscopy is an assessment of the cognitive function. We want to know, what's going on in this person in terms of their neuronal status. Are the neurons functioning well or not? What's affecting them? And so what I mean by cognoscopy, or what he means by cognoscopy, he's talking about doing blood work. Of course, the first thing would be history. That goes without saying. In medicine, if you don't know history, you don't know anything. Everything else is baseless. The first thing is history. And that is why when we do initial consultation, we need 60 minutes. Sometimes I don't think even 60 minutes is enough, to be honest with you. But at least 60 minutes, you need to be able to understand the patient. And then you're going to go and do the blood work and urine test and saliva test and stool test and breath test and sleep studies, imaging studies, all that you need to assess that individual. Now, what are you looking for? You are looking for markers of inflammation. You are looking for markers of methylation, because methylation is a very important process which is required for detoxification. You are looking for markers of infection. So if you look at this picture, do you see the yellow stuff in between the teeth? So there might be a bacteria called P. gingivalis somewhere in here. And that has been linked to Alzheimer's disease. So remember that the mouth is very close to the brain. If you have sinus infections, nasal infections, all of that inflammation can actually go to the brain. Lyme disease is what, Connie talked about, very important to look into that, because that can affect the brain. Herpes, another viral infection that has been linked with Alzheimer's disease. So what you are trying to look at, you're looking at markers of infection. You're looking for toxin exposure. If somebody has silver fillings, mercury, we know, sits in the brain. If you're eating a lot of fish with high amounts of mercury. We're also looking at non-metallic toxins. So for example, all our cleaning supplies, tons of toxins. We are looking at biotoxins like mold toxins. Most of us are not even aware that we are being exposed to that because nobody talks about it. We are also looking at markers of vascular damage. And that is very important because remember that your blood vessels are the suppliers of nutrients and oxygen to the brain cells. If there is vascular damage, there is no way you can expect the brain to be able to function. Then there are markers of blood sugar balance. We know that sugar and insulin are both toxic to the brain. And so if there is going to be insulin resistance, and remember that, the damage to the brain starts even before we are diagnosed with prediabetes. Because remember that we diagnose prediabetes when the blood sugar is between 100 and 126. But when it comes to brain function, we would like to keep the blood sugar 90 or less, because we know that significantly affects the brain. We are also looking for nutritional deficiencies, because clearly there's no way you can expect the brain cells to function without having the nutrients they need. But it's not just nutrients that the brain needs. We know that the brain has progesterone receptors, estrogen receptors, testosterone receptors, DHEA receptors. So if you're not going to have those receptors get what is needed for functioning, then you're again going to have brain dysfunction. Body composition analysis. This is critical. And this machine that you see is the machine that we have in our office. And this is to look at visceral fat. What is visceral fat? Visceral fat is the fat in your belly, which is a huge, huge marker of inflammation. You can close your eyes and say this person has inflammation if you see there is visceral fat. And we actually have a webinar which we have done on weight loss, where we have actually explained how do you look at body composition analysis and how do you interpret that. And if you're interested, you can go and watch that webinar. Leaky gut, extremely, extremely important to make sure that you do not have leaky gut, because leaky gut has a lot of relationship with brain function. And genetic testing, you want to know if you have that risk, what is the degree of risk that you carry. And that helps you understand and customize a plan as to how far do you need to go with this patient, how stringent you have to be with this patient. So those are all the things that you do when you're doing a cognoscopy.
So what do you expect to achieve at the end of the cognoscopy?
So at the end of cognoscopy, we are able to say, okay, what is the subtype of dementia that this patient has? So the first category is inflammatory, where you have a high markers of inflammation. And so the brain is extremely inflamed. The second category is 1.5, glycotoxic, meaning in this case, the brain is being fried because of high sugar and insulin. The third category is atrophic, which is where the brain cells have inadequate support, either nutritional support or hormonal support, which is causing dementia. The fourth category is cortical toxicity. And this is what you can call it the most fascinating, at least for me, because we see this a lot, and this is the one which is mostly undiagnosed. The reason why it's mostly undiagnosed is this happened in late 40s. The patient comes to you and says, I have brain fog. It's very interesting because most of the time, conventional physicians have a hard time understanding what do you mean by a brain fog, because it's not really a characteristic feature in any of the diseases. So the patient will complain of brain fog. So if you ask them to clarify what do they mean by that, they will say to you that, you know, sometimes the words, I cannot get the right words. Sometimes I have slurring of speech. They will have issues with executive function, especially making decisions. Interestingly, these individuals may also have calculation issues, and they are actually ApoE4 negative. So really interesting category. The next category is vascular dementia. And this is something that you see in people who have heart disease and strokes, because remember that both heart disease and stroke is related to blockages in the blood vessels. So in this type of dementia, the primary issue is that there are so many blockages in the brain that the supply is not there. And that is why that individual is having such a hard time with memory function. And last but not least is trauma-associated dementia. And we know that anybody who has moderate traumatic brain injury is 2.3 times at greater risk of developing Alzheimer's. And if you have a severe brain injury, then you are 4.5 times at higher risk of developing dementia. So those are the subtypes. Unfortunately, most people have multiple areas of dysfunction, which means it's highly unlikely that somebody is going to be inflammatory or, you know, because remember that there are similarities. If you're going to be inflammatory, it's possible the inflammation is coming from the sugar. So there is definitely, times when you find, oh, this is like 3 different things going on or 4 different things going on. So you will not have pure subtypes, but at least this way you can categorize, okay, these are the categories, which one do you want to start with? You know, how do you want to deal with it? Which one is the easiest one that you want to do? So on and so forth. So that is where your clinical judgment will come in, where you will say, okay, in this person, I think this looks like to be the one that's causing the rest. So let's start with this. So that is where your clinical judgment is going to come, where you will say, okay, this is what I want to do.
When we say that we can reverse dementia, what does it really mean at the cellular level?
So that is an excellent question. And this is something I want us to understand. There are certain concepts, there was a time we used to think that, once you're born, you have a certain number of nerve cells and that's about it. And that's how they will remain for the rest of your life. And we now know that's not true. We have a new concept now, which has come in the last 10, 15 years. It's called the concept of neuroplasticity. What neuroplasticity means is the brain has the ability to change its structure and its function throughout the life. So you can have a change in structure and function throughout the life, which is dependent on the environment that we provide to the cell and the experience of that individual. Which is the reason why you will see that some people, even if they are 90, 95, 99, they are very clear in their brain. They know exactly what's going on. Their physical body may not necessarily be that, in line, but mentally they're very sharp because you have the ability to change, modify your structure and your function. And this is precisely what we see when somebody has stroke. So when you have a stroke or when somebody has a stroke, there's an area of the brain which did not get the blood supply and that area dies. So there's a small area which is dead. So what happens is that the neurons or nerve cells around that area, they get together and say, okay, no problem, we're going to come together and we will see if we can take over this function. And that is why there's so much emphasis on rehab, because what is rehab doing? Rehab is trying to increase and accelerate neuroplasticity to allow the other neurons to take over the function which has been lost because of the death of certain number of brain cells. So that is concept number one. Concept number two is neurogenesis. So the concept that we cannot produce any more brain cells after our process of development is again not true. We know now that we can form new neurons in our brain, and those neurons are made by neural stem cells, and this process occurs throughout our life. And there are certain areas of the brain which have the capacity to produce new neurons. So when we say that we want to reverse cognitive decline or reverse dementia, what we are trying to say is we are trying to boost the process of neuroplasticity and neurogenesis. The third concept is a really interesting and important concept which is discussed by Dr. Dale Bredeson. He talks about synaptoblastic and synaptoclastic activities. So let's first understand how neurons talk to each other. So if you see there are two neurons or nerve cells here, and you can see one of them has a long tail, the other one has a long tail. And so the tail and the head talk to each other. This is how they talk. This is what we call synapse. The point where they connect is called synapse. So I think what Kathleen said to me, I thought she was a really good analogy. She said that when the neurons are having a blast, they're having a great time, then they make lots and lots of connections. And the more connections they are, the better the function, because they're connecting better, they're communicating better, they're singing together, they're dancing together, and voila, you have a brain which is vibrant. Synaptoclastic, you can understand, is clash. Clastic, if there is clash of neurons, miscommunication of the neurons, if you provide them an inflammatory state, then they will become synaptoclastic, meaning they will clash with each other. They will actually stop communicating with each other. And that is when you will see a lot of neurological issues. So in an optimal brain, you want them to have a blast, which means you want to have synaptoblastic activity. But when you have the opposite, meaning when you have more synaptoclastic activity, or when they start clashing against each other, then we have loss of brain function, memory loss, loss of cognition, and downsizing of the brain. And so reversal simply means that you are optimizing synaptoblastic activity. So that is what we mean when we say that we are trying to reverse the brain function, or we are trying to prevent decline of the brain function.
Earlier, you mentioned that during the cognoscopy, you test for leaky gut. I know we talked and spoke about leaky gut. We spoke about leaky gut on the previous webinar, which you can find on our YouTube channel. But what exactly is the role of leaky gut in dementia?
Interestingly, leaky gut actually affects literally every single category of dementia with the exception of traumatic. So just for those who do not know much about leaky gut, you can definitely look at the webinar. But in simple terms, if you see here, this is the normal area where you can see these yellow dots. This is what we call security. And here there's no security. And you can see everybody who wants can actually get into the bloodstream. It could be bacteria, it could be bacterial toxin, it could be fungus, it could be undigested food. When this is going to enter the system, it's going to cause inflammation. This inflammation goes to the brain and you have the category 1. When you have a lot of inflammation, you develop insulin resistance. There you go. You have the category 1.5 of the dementia subtype. If you have this situation in your gut, it is highly unlikely that you are going to be able to absorb nutrients. And you go to the next category, which is atrophic form of dementia. And of course, you are also getting a lot of toxins from here, and you get to the next category of toxic dementia. And the last one is vascular. We know that gut actually determines whether you have a dysfunction of the lining of your blood vessel or not. We actually know people, actually had a patient which was very interesting. He came with high blood pressure. And he absolutely was sure. He said to me, Dr. Ali, I don't have high blood pressure. They keep on saying that, they keep on putting me on a medication, but my blood pressure goes up, but then it comes down. It's strange. And he was actually right. His blood pressure was a direct result of what was going on in his gut. So our blood vessels can contract and relax depending on what's going on in the gut. And our blood vessels can actually have plaques depending on the degree of inflammation that they have, again, related to the gut. So almost every category or subtype of dementia can be linked to leaky gut. And I'm going to show an experiment, which when I saw that, I was like, well, this is another level, because when I used to think about leaky gut and brain, I would always think that, you know, it's about the lining. The lining is breaking and this is happening. Till I saw this experiment, I was like, no, there is multiple ways this can happen. So here is the experiment, which I thought was pretty cool. So I want you to understand this. This is a mouse, and this is the stomach of the mouse, and this is the brain. So what they did was they took a toxin and they injected into the stomach. Now remember, this toxin has not gotten into the intestine yet. It is just in the stomach. And remember that our absorption happens in the intestine. When they put this toxin in the stomach, remember that the stomach has a lot of nerves, and then those nerves connect to the vagus nerve, which goes to the brain. The toxin actually went through the vagus nerve to the brain, and the rat developed Parkinson's disease. Then what they did was they took another set of rats and they cut the vagus nerve. And voila, the rat never got Parkinson's disease. So this is very interesting that it is not just the connection as far as the lining is concerned. There are other forms in which toxins that are going through the gut can actually go and get to the brain. So this is extremely important to address. And I think I have seen this firsthand in situations that I have been shocked. I have been shocked to see how enormous. Sometimes we have patients, they have 2 to 3 types of subtypes. And you're thinking, you know, I think that, you know, the toxin would be, sounds like the worst case scenario. But when you fix the gut, suddenly you see there is a 180 degree of change. And you're like, oh, well, the toxin is playing a role, but nowhere compared to the gut. So I think that this is really important to look at the gut. And remember that 90% of signals go from the gut to the brain, and 10% come from the brain to the gut. That's one thing. The other fact, which as I was looking at, I was going through one of my IFM conferences, and one of the speakers said something very interesting, and I cannot forget about it. He said that 30% of the proteins that are found in the bloodstream, in our bloodstream, are actually products of bacteria, which is like, oh my God. I mean, so we are really what our bacteria are. So we cannot disown them, unfortunately.
So you've done the cognoscopy, you found the root cause. Dr. Ali, could you tell us more about what you do after finding the root cause?
So the next thing that we have to do is to develop a customized plan, because you have to understand that, you know, everybody is unique. And until and unless you're able to really understand their problems and their context and their causes, it is not, even though it's called a protocol, it's really a customization of what you're going to need. So for example, if you look at this, if you look at a patient who comes to you and who gives you their story, you will see that almost every patient has many layers to why they have developed this problem. It's never a single hit. It's always multiple hits at multiple times, and they're accumulating. And then once you have removed the cause, then you will see that there's going to be clearance of amyloids, and you're going to see that the neuronal function is going to be optimized. So what I mean by a customized approach is, first of all, what are you eating? I just talked about leaky gut and how important bacteria are, but we are the ones who decide who's going to live inside us. So according to Dr. Dale Bredeson, mild ketosis works very well with some of these patients, but you have to be careful. You have to be careful in people who are very thin. You have to be careful in people who have cholesterol issues. You have to be careful in people who have other metabolic issues. One thing which works for everybody is plant-rich diet. And I've always said to people, I'm not saying you need to be vegetarian, but you need to have a plant-rich diet. And that is very helpful. Again, the exception here could be somebody who has major gut issues and they cannot eat X, Y, and Z. So you really have to be able to figure out how you will get them the nutrients that they need. The second thing is movement. Movement, we know, is the key to brain function. But what type of movement? Again, there is a way to introduce movement. You want to know, do you want strength training? Do you want core? Do you want balance? Do you want aerobics? So you need to be able to define it for your patient and help them achieve their goal. The third tool, which I think is very important, is fasting. Fasting comes in many forms. You can have intermittent fasting. You can have some modified fasting protocol. You can have 5x2 fasting. And the reason fasting is so critically important is because when you fast, you do two things. The first thing you do is what we call autophagy. Auto means self and phagy means eating. So what you're doing is you are eating yourself, meaning that you are eating up the cells which are inefficient and ineffective. So you're really cleaning the system. And then you are saying that, okay, we have gotten the cells that are not working out of the system, and we're going to bring stem cells. And the stem cells will make us the cells that we really need. So it's really a rebuilding phenomena that happens when you are fasting. And fasting significantly helps the brain, because if your brain is not functioning, you do need stem cells to make more brain cells. And of course, you need to clear up the crap in order to provide space for the newer people to kind of come and establish themselves. Sleep. I cannot overemphasize the role of sleep. And I see a lot of people who come and tell me, Dr. Ali, you know, I don't have any time. I'm really short of time. And I have to tell you, you know, this is the one thing that I really loved about Connie, and I'll be upfront about it. And I really respect people who, when they come, they are very clear about their priorities. You have to be clear that, you know, no matter how busy you are, no matter where you are, there'll never be enough time. First of all, that is one thing. You will always find something to occupy your time. But you come first. Your health needs to be in the priority list. Because if it is not going to be the case, at some point you'll have to pay the price. You decide to pay the price now, you decide to pay the price later, it's up to you. But when we sleep, there is a lymphatic system in the brain, which is called the glymphatic system, which is what clears the amyloid and the debris that you have in the brain out of your brain. So if you don't give the brain a chance to clean the debris, and then you complain that it's full of debris, then it's not really the brain's fault. So 7 to 8 hours of good night's sleep is very important. You know, I often tell people that balancing of mind-body is extremely important. Disconnect is very important. If you have major stresses in your life, if you have had trauma in your life, you know, you have to figure out how you are going to get over that. Because if you're not able to do that, even if you get 8 hours of sleep, you're not getting any sleep because you have a subconscious, and people will tell you, look, I cannot meditate because my brain is all over the place all the time. What does that tell you? That tells you that something needs to be cleaned in order for you to have the perfect sleep. The other thing with sleep is that a lot of people have sleep apnea. Sleep apnea goes undiagnosed a lot of times. And the reason is because a lot of these people are not overweight. And if you have sleep apnea, you're going to have issues with the brain because oxygen supply to the brain is being disrupted. So if you have somebody with memory issues and you have the slightest possibility that they could or they might have sleep apnea, then they should be checked for it. There's a term that Dr. Bredeson coined. It's called dementogens. You know how we talk about carcinogens. Carcinogens are chemicals which cause cancer. And dementogens are chemicals which cause dementia. And we are surrounded by those chemicals. And so as a functional physician who is trying to do the ReCODE protocol, my goal is to find out what are the dementogens in this particular case. So we had a very interesting case. We had a woman, we found mercury in, and she said, I have no fillings. I don't eat fish with high amount of mercury and don't use any plastic. She also had some plastic in the system. She had some lead in the system. Now we are sitting there. She is very careful about everything and we can't figure out. And we're like, okay, so do you do this? No. Do you do that? No. And then suddenly she said something very interesting. I asked her, do you use dye, hair dye? And she goes, yes. And I was like, that's it. So, it took us almost an hour of discussion to be able to figure out where is this coming from, because obviously she was not using any cosmetics. She is using the perfect cleaners in her home. She has this water cleaning system. So you really have to understand and really have to find out where is this coming from. So that is how we kind of identify and address, what's going on and how we make sure that we remove all the dementogens.
So, Dr. Ali, what are some other non-invasive tools that you use to help your patients?
So we use infrared therapy. This is basically a combination of infrared light and high heat and vibration. This is an outstanding therapy, especially with people who have toxic exposure. Unfortunately, we all have toxic exposure, whether we like it, we don't like it, unfortunately, it doesn't matter because we're all exposed to it. And this is when you have high heat, your blood vessels actually expand, allowing the flow of nutrients. And with the vibration, your lymphatics actually get all the crap out of the system. And then they use the skin, which is the biggest organ that we have, to kind of expel this stuff in the form of sweat. And infrared actually activates mitochondria. And mitochondria is the powerhouse of the cell. You need energy to detox. You need energy to function. So this is a great tool that we use in a lot of different situations. And one of them is the dementia or Alzheimer's disease, particularly the third type, the cortical or toxic subtype. The second tool that actually, this is the newest addition that we have here, is the IASAS Microcurrent neurofeedback. This is an advanced form of neurofeedback. It's very effective and efficient. We are finding that we have 85% response rate in 1 to 3 sessions. And so the way this works, so the way neurofeedback works, since neurofeedback has been there for a very long period of time, is that neurofeedback believes in the principle of what we call retraining. So what you're saying is that the brain has been trained in a way it should not have been. Now we are going to retrain the brain. So when you do retraining through regular neurofeedback, you are dependent on the trainer. So if I'm teaching a skill to 3 people, how quickly will they learn? It will depend on how quick they can pick up the skill. IASAS works on a different mechanism. What IASAS does is IASAS tries to unfreeze the brain instead of waiting for the person who's having the problem to kind of go ahead and solve his or her own problem. So this is basically something which can not only help dementia per se, but it can also help with causes of dementia. For example, PTSD or mood disorders, which accompany a lot of these patients with dementia. And it's also used in people with traumatic brain injury, which we know is one of the toughest things to deal with, because you've already had an injury and now you're trying to repair the brain. So that is another tool that we use. So we use a lot of different tools in our toolbox, and every tool is not for everybody, you know, and that is why customized approach is so important, because you are looking at IASAS, you're looking at lifestyle, you're looking at bioidentical hormones, you're looking at botanicals, you're looking at different forms of nutrient therapy, so on and so forth. And of course, you're looking at detoxification as well. So all of those tools we have in order to be able to customize it to the patient.
Thank you so much. That concludes today's prepared questions. If you have any questions for Connie or Dr. Nadia Ali for today, please go ahead right now at this time, place them in the question and answer section down at the bottom. So I'm going to go ahead and I also get to, while I go, so sorry about that. I said, go ahead and please place your questions in the question and answer section while I go ahead and introduce our topic for next time. We will be talking about freedom from autoimmunity. It'll be on February the 27th at 4 p.m. Registration is required and seats are limited. Please go ahead and register now. We will be talking about autoimmune versus autoinflammatory diseases, why the body is attacking itself, who is the hidden enemy, the mediators of autoimmunity, and rebalancing the immune system. So if you've had any, if you have any questions, or if you have had any challenges pertaining to autoimmune or autoinflammatory diseases, we would love to hear some of your challenges and things you've overcome, as well as any questions that you have. Feel free to email us at email@theholistichealing.org. Okay, so I'm going to go ahead and look for the questions. Okay, so Dr. Ali, you mentioned dementia is misdiagnosed. Why is it misdiagnosed so often?
So what happens is that dementia does not, first of all, always come in the form of memory loss, which is what people think, that if you have memory loss, that's dementia. Like I said, cortical dementia, you will not have memory loss. You will have brain fog, you will have slurred speech, you will have issues with executive function, issues with taking decisions. So it will come in that form. In some cases, people will, because of these issues that they're having, they will become irritated and agitated, and they'll be diagnosed with anxiety, or they'll have issues with concentration, and we'll diagnose them with ADHD. But that's not really it, because you have to look at the whole picture. And if you look at the whole picture, and if you see, well, there's an anxiety element, there's a concentration element, but then there is also the slurring of speech, there's also loss of executive function, then you will know that it's not really anxiety or ADHD. Those are part of a bigger picture, and that bigger picture is neuronal function, which is suboptimal.
So I am a medical marijuana patient. Does THC have any bearing on dementia, either positive or negative?
So again, it has to have bearing on dementia. Positive or negative will depend on why it's being given to you and how it's affecting you. We know that there are CBD receptors in the brain, there are CBD receptors in the periphery. And in some cases, like when I don't use marijuana, I use pure CBD. And we have seen some really positive effects in CBD. So I prefer to just work with CBD because THC has its own issues with it. But yes, it can have effect, and depends on the dose that you are using, depends on what you're using it for. So remember that anything in medicine, even water, is not positive or negative. It's a tool. If you use it properly, you will get the benefit. If you don't use it properly, you will be at risk. So it's not the problem. It's the water is not a problem. It's the person who's using the water. Do you know how to use water? If you excessively drink water, you will get hyponatremia or low sodium. But that has nothing to do with water. It has to do with how it's used.
So you had mentioned, I think it was gingivalis as the bacteria in the mouth.
Gingivalis, correct.
Could you Could you talk about how that's diagnosed and treated?
So one of the things is that, the most important thing, just to make your life easy, is to look at the oral health of that individual. If there is bad breath, if there is gingivitis, if there is gum recession, clearly that's a problem and that needs to be addressed. You don't necessarily have to identify P. gingivalis. You could have another bacteria which can also go into your brain and cause a problem. But mouth health, this is the place where we give least importance. There is no insurance. Insurance doesn't cover it. But this is the most important part in your body because it affects almost every single disease, including cancer. So the gut starts with mouth. So that is why when we take a history, we really want to make sure that your mouth is okay, because that's where everything's going to start. And that's a very simple way that you can figure out if you need to treat the person's mouth or not and how you're going to go about doing it. That's all the all the things that you're going to do to be able to address what's going on in their mouths.
How does one treat cortical dementia?
So cortical dementia is basically a subtype where we know it's the toxin that's causing the problem. And so the first goal is to find out what the toxin is. The second is to know why is the body not able to eliminate it. And so until and unless you are able to find out how to get rid of this toxin safely, and I keep on saying safely when I talk about detoxes, because detox is a very, very, very heavy duty process. And that is the last thing that we undertake because it's very heavy duty. So before that, you have to make the system so good that it is able to get rid of some of the crap. Because we are always going to have toxins. So obviously you're not going to chelate the person for the rest of their life, right? So they should have some way of detoxing. Like, for example, I would tell somebody that, okay, I want you to do infrared hyperthermic therapy once a week or so, just so that you can get rid of some of the stuff. But if that is very high level of toxin, which is really having an impact, then you will have to undertake chelation. But prior to that, there are a lot of steps that you will have to do. We did a webinar on mercury toxicity, and I suggest that you look at it because we have actually talked about chelation in much more detail in that to tell you how you can address that.
Do any of the dementias have dizziness as a symptom?
Yes, dizziness is a very non-specific symptom, but one of the things which is very clear, if you have dizziness, what you have is you have autonomic issue and or nerve dysfunction. Because remember that dizziness is a sensation that you're lightheaded or you're going to fall. And it's a sensation which is coming from nerves. So yes, it's not unusual for somebody who has any kind of neurological disorder to actually have dizziness as part of it.
Okay, with the dizziness question, I'm going to go ahead and ask this one now. You've referenced head injuries. Are concussions playing sports as young adults, how do they relate to dementia?
Definitely, a concussion can be mild, moderate, or severe. And if you have moderate degree of concussion, severe degree of concussion, that is brain trauma. That's categorized as brain trauma 101. Definitely, that's exactly what I'm talking about when I say the last category of the last subtype of dementia.
How does PPI use affect the brain and Barrett's esophagus as well?
How does PPI use affect the brain? So PPI is basically suppressed acid, and the presentation that we did on IBS, we actually presented at least 2 slides which showed the PPI have impact on almost every single part of the body, which includes the brain. Because remember, the acid is the first line of defense against bacteria and fungus. So if you're going to suppress the acid, you are not going to be able to do your gut any favor. So that's issue number 1. And there is a possibility of leaky gut as well. But remember, the stomach is also the place where there's a lot of absorption of nutrients like B12 happens. You need to have stomach acid for you to absorb B12 and some other nutrients. So if you're going to block that, then you expect your brain to get all the nutrients? Not really. Now, you've mentioned the other condition, esophagitis, right? Barrett's esophagus, actually. Barrett's esophagus is a precancerous diagnosis. It's a very severe and very serious situation, which happens in people who have had a lot of acid which has gone into the esophagus. Again, you have to find out why that's happening first. And clearly you cannot just stop PPI if you have Barrett's esophagus. You really have to go to somebody who understands what's the cause of Barrett's, how is it kind of happening, work on it, get that resolved, and then they can take you off of PPI. So again, there is a method to the madness. You can't just go and say, oh, PPI is bad, I'm going to take myself off of it even if I have Barrett's esophagus. You can't do that.
So you say that, so looking at the infrared treatments, I have a couple, I have 2 or 3 questions on them. One of them is how long is the session? And the other one is the infrared therapy near or far infrared?
Far infrared, and sessions are like you start with 15 minutes and you go all the way up to 60 minutes. The same thing with the degree of heat. It's a different level. There is low and moderate and then high and then hyperthermic and high hyperthermic. But one of the things is the head is always outside. The hyperthermic therapy that we give in the office, the head is always outside. Because remember, the head houses a lot of sensitive organs. So you don't want to put the head to the high heat. You want to put the body to the high heat, not the head into the high heat.
And you said that infrared treatment works for all types of dementia?
In most types of dementia, in particular inflammation and in particular cortical. Actually, it will also work in the glycotoxic one.
My mom is in denial of her symptoms. She seems around stage 4, refuses to see a neurologist. Is there another step I can try to get her some help, support, or information? See even a functional practitioner for an overall health assessment. How do I find one? That's actually a question of a couple people on here, is how do I find one? So this particular person is from California, Southern California. The others are in Arizona. So we have a few different people also asking if you take people virtually.
Yeah, we do take people virtually, and but there are 2 questions here. We do take people virtually right now, more virtual because of the COVID-19 situation. There are certain rules that we have, like once a year, you have to be able to show your face as long as we don't have COVID-19, because that's part of the establishing of the contact. But I think as far as the mom is concerned, who's in denial is part of dementia, first of all. So I think what she's doing is what a lot of people do. But I think that there's more than just, there's a reason for the denial, first of all. You know, these people are very scared. If you're losing your mind, you are going to be very scared. And so the most important thing would be to actually sit with her to find out what her goals are. So instead of working on your goals, work on her goals, because there is going to be a goal that she has and you have that is common. And that may require her to have better brain. So that way she's not feeling that somebody is pushing her to do something. She's doing something that she wants to do. And maybe for starters, what you can do is you can have a heart-to-heart discussion with her as to what she wants for herself.
Do you know anyone in the Austin area with similar expertise?
I don't know, but what I can tell you is that if you go to the website Institute of Functional Medicine and you can put your zip code, you might be able to find a functional practitioner who you may be able to trust and who actually has the expertise or who has worked with Bredeson protocol, Walz protocol, and who knows how to go about doing this.
If all metals are normal and other labs abnormal, what other ways of finding toxins are there? They might.
So there's a mycotoxin test if you want to look for mole toxin. There is a test to look at non-metallic toxins, like for example, fertilizers, pesticides, herbicides. So there are lots of tests out there that you can do. But again, you're not going to do every test in everybody, otherwise they'll go bankrupt just trying to do the testing. So you just do what you really think, depending on the history, what you need to do.
Can a brain bleed during delivery be a root cause of dementia later in life?
If a brain bleed is almost like having a stroke. Okay, there are 2 types of stroke. There is a stroke where you clot, or block your vessel, and there's a stroke which happens because you bleed. And because you're bleeding, the supply again is stopped to the area that the blood vessel was supplying. So yes, it could be something that you need to look into, and that can contribute towards the problem.
Do you, or are there other labs, or it says other labs are normal? Oh, sorry, it was a correction from our last one. So the other question I have is, do you have any specific supplements that you recommend for cognitive health and dementia/Alzheimer's? And then on top of that, I would like to put this one there with it is, you mentioned CBD for pain. Are there any over-the-counter supplements, and what is a good dosage for memory for CBD?
Again, so there are a couple of things. First of all, there are no supplements that we give to everybody, because remember, that was the whole point, that it is supposed to be customized, number one. Number two, we do give CBD. Again, the dosing is different, and every patient determines their own dose. We tell them how to start. We actually tell them how to make the oil themselves, and then they dose it according to what their needs are, because you don't want to go too high, you don't want to go too low, because either way you're going to be jeopardizing yourself. So I do not recommend that you go and over the counter buy something, God knows what it has, how much purity, has it been checked for impurities or not, and then God forbid something happens. The best thing is then to go to a physician who can kind of sit down with you, and CBD may not even be the first line. CBD is not necessarily my first line. I try other things depending on what's the cause of your pain. You have to first know what's the cause of your pain. Don't just throw a band-aid at it, because that's not going to solve the issue. And how long are you going to take the CBD? If you have a reason, then it's a different story. But if you don't know, you're just band-aiding it, you're still going to be in trouble.
What is the name of the infrared hypothermic machine that you use?
That's a good question. Let's see, what is it called? I can definitely, you can email me, I'll give you the name of the machine. I'm trying to think. Actually, you know what? If you Google cocoon, then you will find it.
So I think that concludes today's webinar. I wanted to give Connie, is there any last things as well? I wanted to thank you for coming on and speaking.
Oh, you're welcome. I think this was an excellent variety of things that you touched, and having had my mother have traumatic brain injury, and that is really, they didn't know at that time. That's what they said. She had Alzheimer's, but it was traumatic brain injury. We figured that out when she was in a nursing home for 11 years. After the 5, we had already taken care of her at home. So all I can say is when it goes on that long, it's something else. And she had 2 massive brain problems, you know, fell and whatever. So yes, these are very important things to be careful of.
I did just get another question that would be really great to add to this, I think, would be menopause can cause brain fog as a symptom. Does that mean that women are more likely to get dementia?
Well, we know that women are more likely to get dementia because you have statistics saying that, you know, more women than men are affected by Alzheimer's dementia. But the question is whether that's because of a loss of estrogen or not. That's what the question is. And the truth is that, you know, menopause does not mean not having estrogen at all. That's not true. We all have some amount of estrogen, even when we are menopausal. The problem happens is that if you have a system which is not working, and that is why you are not producing adequate estrogen. And that's why, you know, when you are evaluating somebody, before you put all the blame on estrogen, you want to make sure there isn't anything else going on, because menopause is a change, which is not just hormonal change. A lot of other things happen when women go into menopause. There's a metabolic activity that happens, you know, change in metabolic activity happens. Actually, gut flora can actually change, you know, because your hormonal signals are changing. So menopause is not as simple as lack of estrogen, which is unfortunately how it's often defined. And so you need to understand, first of all, how do you have that person optimize their own estrogen? And then you have to figure out what other changes are happening which could impact the availability of estrogen to the brain. And of course, if nothing is going to help, then you will, as a last resort, can put somebody on bioidentical estrogen. But there are a lot of issues. And to say that menopause is what's causing brain fog, then every woman should have brain fog who gets menopause. And that's not the case. So menopause is not the cause of brain fog. There's something else that's happening, and it was already happening. And when you got into menopause, you overwhelmed your system, which was already broken.
Mm-hmm.
So, you know, a lot of times when you're pregnant and you have a problem, then they say, oh, it's because of pregnancy. Oh, no. Blood pressure, high blood pressure during pregnancy, they say is because of, you know, pregnancy. Women has diabetes during pregnancy, they say, oh, this is because of your pregnancy. No, that's not true. You already had a problem. And now because you're pregnant, your system, which was already overwhelmed, is now breaking down. So then the thousands of women have given birth to babies. Nobody had high blood pressure. Nobody had high blood sugar. Suddenly you have a problem and that's because of pregnancy? No, that's not the case.
Thank you so much, Dr. Nadia Ali. And that completes today's webinar.
Thank you so much, everybody. Bye-bye.